So our next presenter is Willem Alffenaar, who will talk about pharmacokinetics. Jan Willem. Oh, you can use that or the one here, whatever you prefer.
Okay. Thank you for the opportunity to talk today about pharmacokinetics, and I changed the title a little bit. Oh, it's yeah. Okay, yeah. Thank you for the invitation to talk about pharmacokinetics today. I changed the title a little bit about what's new, because I didn't want to keep talking about the same stuff. So for the 15 minutes that I have, I selected 3 topics. The first one is making better use of the properties of the drugs. There's opportunity to monitor cumulative drug exposure and some new point-of-care assays. So this is what we already know. We select drugs based on susceptibility. We know that standard drugs have a standard concentration profile, and we hope that that concentration profile fits within the range that it's active and not too toxic. And based on that, we select our dose frequency and dose, and often that ends up with a daily dose. But if we now know how these drugs work based on PK/PD, we can do some other stuff. And people have been doing this for quite a while already. We started with the aminoglycosides. We started giving them daily, and then we changed the dose and we gave it 3 times a week, and it was equally active and in some cases a little bit less toxic, so we were happy with that change. But then we started doing this for the first-line treatment. Only what we forgot to do was to change the dose. We just gave less drug. And then we were surprised that we saw more resistance, more treatment failures. And even this study recently published in 2020 in CID came to the remarkable conclusion that 3 times a week 600 milligram rifampicin was not enough. But if they looked at this study from 2007 and they looked at rifampicin dosing and dosing frequency, and in this study, they looked at giving the same weekly dose, either divided or as a single dose. It resulted in the same kill. And we know from other models that it's AUC over MIC that drives the efficacy of rifampicin. So you could already have predicted that your trial published in 2020 was going to fail. So clearly, we pharmacokineticists do something wrong because we don't reach the right people. So if we look at suppression of resistance due to rifampicin, they found out that it's the free peak concentration over MIC that is important. And that value is over 175. So you have to give a ridiculously high dose to achieve that. So we're not going to make that effect within our current regimen. So we need the additional drugs to prevent rifampicin. But at least if we look at the post-antibiotic effect of 5 days, we could look at that weekly regimen. So then we go to the new designed regimens. And this is an interesting paper published last year in ARJ, where they actually thought through this whole concept of AUC over MIC dosing and making better use of these half-lives of the drug. And they combined rifampicin and bedaquiline and provided a weekly dose to these Swiss mice. And they, of course, combined it with pyrazinamide and moxifloxacin because that's relevant, we know. And when they looked at the outcome, they saw that the relapse rate, which is, of course, important with these shorter regimens, that there was no difference between this once-weekly regimen for 4 months compared to the standard daily regimen for 6 months. So clearly, there's opportunity of designing a regimen for susceptible TB that might work with a less intense dosing regimen. Of course, there are some clinical issues that we need to solve. First is the tolerability of this once weekly high dose of bedaquiline. And of course, we need to verify the bedaquiline exposure when we give these drugs in combination, because rifampicin and also rifapentin reduce the exposure of bedaquiline with about 50%. And when you talk about reducing exposure of bedaquiline by 50%, you're actually paying a lot of money for lower exposure. So moving on to the second topic, and that's monitoring of drugs. Of course, we've been monitoring drugs in saliva, plasma, urine, etc. But because of the short half-life, this is not very helpful in looking at long-term accumulation of drug or adherence to drug. But if we're looking at, for example, hair, there is opportunity because drug accumulate in hair, depending on drug properties, of course. And this has been done quite a while for other situations, and I think most of it was driven by, let's say, not taking drugs of abuse, so this should be absent in hair. But now we can also look at the presence of drug in hair for a different purpose. And of course, hair is easy to collect, easy to store, easy to transport, it's stable. And this is a picture of how currently hair is collected and analyzed, and it is quite a laborious procedure, especially in the lab. But this study, recently published, showed when they looked at a significant cohort of over 260 patients, and they looked at the hair concentration of the first-line drugs, and they looked at some relevant primary endpoints like treatment failure and 2-month culture conversion. They showed that the patients who had higher exposure in hair had a better treatment outcome. So with this cumulative, let's say, trapping concentrations of drugs in hair, they could show that over time these patients clearly absorbed more drugs than other patients, and that resulted in better outcome, as we would expect, because these drugs are driven by AUC over MIC. The only thing is this current analysis of hair is very laborious. It takes a lot of time. It takes a lot of hair. So there is new innovation in this part, and that's done by MALDI-TOF analysis. So this means that there is direct extraction of a single hair for the drug concentration. And the other advantage is that the resolution is much better. So with the traditional method, you can look at periods of 1 month. So that's not really useful when you want to look at detailed compliance, for example. But with this new procedure, you can look at a day or even shorter periods. So then it makes more sense to have more frequent single hair analysis to look at, let's say, adherence monitoring. So what we would like to do, because we were funded by the TB-CRE to do a PK study for first-line drugs, and we were planning to include saliva. What we will now do with this new potential assay is collect a single hair in each patient and look how the exposure in plasma and saliva translates into the concentration in hair. So therapeutic drug monitoring, it's already included in some of the guidelines. It's recommended to be considered in case there is a problem with your patient, and that problem can be caused by drug-drug interactions, malabsorption. You see no response while there is a susceptible strain. There is some toxicity, and when we look at the picture, we see a lot of different PK profiles, and it is somehow real life, because indeed we see that variability in real life. But the problem is that due to the lack of evidence, there's no randomized controlled trial. And there is a lot of, on the other side, hurdles to do that trial or to implement it in high burden settings, like invasive sampling. Then you have your unstable sample, so it doesn't arrive in the lab on time, or the equipment is too expensive. So we need to break this cycle and do something else. So a little while ago, we started off rethinking the current strategy of therapeutic drug monitoring, and we thought of we need something that is suitable for community TDM. So it should be easy, it should be cheap, it should be fast, it should be, let's say, readily usable. So we thought of these hurdles as academic opportunities, because we can do studies and find some solutions. So for the invasive sampling, we can look at saliva, urine, and dry blood spots. If we're talking about sample stability, again, we could look at immediate analysis of the sample, so there's no time of your sample to decay, or you could look at dried blood spots, so sending it off through a, let's say, stable sample. Of course, expensive equipment, we wanted to replace it by cheap equipment, and we were looking for something simple. And if you look at these countries and you visit these countries, you see that dried materials are frequently used. If you go to the market, dried fish, dried meat, so there should be an appetite for dried blood spot samples. So it's about creativity, innovation, and a little bit of DIY. So we looked at saliva monitoring, and quite a few drugs penetrate in saliva. So we have access to that sample. We also show that we can do it safely by filtering the sample, so we get rid of the few mycobacteria that are present in saliva, so we don't contaminate our lab people. Oh, sorry. So this is the first essay that we published, supported by the Gates Foundation for levofloxacin, and we showed that we had a nice correlation with respect to the levofloxacin concentrations. It was sufficiently precise and had no interferences with other drugs except for rifampicin, but for most of the patients with MDR-TB, this is not a big issue. And most important, this assay is run on this small device. It's battery operated, so you can take it with you when you go somewhere to a village to do your healthcare services. So this is our first pilot study we performed in Tanzania at Kibongoto Infectious Diseases Hospital. And for the sake of time, I highlighted the final sentence of this slide. We were able to identify 8 of 9 patients with drug exposure below target. So if we're talking about identifying patients at risk for acquiring fluorocolone resistance due to low exposure, I think this is an important first pilot study. So based on that, we were encouraged to also look at linezolid in saliva. And again, we produced these very nice graphs with an exposure-response relation that was very nice. The only thing is linezolid had a considerably much more interferences with other drugs in saliva. And that's simply the case because of the wavelength of a drug. This is a characteristic of a drug. So if you have, let's say, a drug with interferes with other drugs at the same wavelength, you get a wrong result. And the main problem was that with this type of assays, you don't have your regular sample cleanup like you have with HPLC or LCMS. You don't have chromatography to separate your samples from each other, so separate your compounds. But if you're a little bit clever, you can sort it out by just looking at what we're doing with our patient. So when we look, for example, at the Piracinament Interference, we noticed that the interference was only at the higher level of pyrazinamide and not at the lower level. So if you take the drugs at the same time, you have your trough level of linezolid, your trough level of pyrazinamide, so likely there's no interference at all. So this is a way to get rid of this interference problem for some of the drugs. So currently we're working on a sub-study of the V-SMART, as Greg yesterday already mentioned, and we are going to see how the exposure in saliva for levofloxacin and linezolid can be associated with the treatment response and the toxicity of the patients in the V-SMART study. So hopefully next year we have some first results of this project. So finally, rifampicin in urine, as we're talking about DIY, the people in University of Virginia, they developed a very nice box and used by 3D printer. And as we know, rifampicin is a nice coloring drug. So what they looked at was the rifampicin exposure in urine and measured it with a smartphone and a color matter on your smartphone app. And they produced a very nice correlation based on the absorption of that smartphone app and the concentration they spiked in urine. that's all good, but when they actually did a similar experiment in real life in patients where they collected both plasma samples as well as the urine samples, they were able to distinguish between patients who had too low levels compared to their plasma concentrations. So in this case, they were able to identify all the patients with too low exposure. So I think there's opportunity to also look at point-of-care assays for rifampicin. And on the bottom of the slide, I mentioned urine assays for other drugs. So I think there is a great opportunity for this type of assays. So when we're looking at the new framework of therapeutic drug monitoring, and we start in the community, we have our assays that we can run on site with the printed box and the nanophotometer. You can, of course, collect your samples, and the dried samples can be shipped to a different location because of sample stability than your plasma samples, because we have our regional laboratories and our central laboratories. We can ship the dried samples even to our central laboratories because they're stable for sufficient periods. And last but not least, we can add our hair sample analysis as well. Unfortunately, they have to be sent to the central laboratory because MALDI-TOF is not operational at the regional level. But I think if we're talking about adherence monitoring or cumulative drug exposure, you don't do it by a weekly basis. So if you do that, for example, once a month, there is some time for a sample to travel to the lab. So if we're making some conclusions, if we can better understand and apply PK/PD, we can move on to weekly dosing to make it more feasible for staff and patients. There is opportunity for the first time to actually look at cumulative exposure and adherence monitoring in TB treatment with the hair analysis. And I think with the new type of assays, we can actually measure where our patients are and not at a remote site. So the technology is ready, so yes, we can. So now we can actually do our randomized controlled trial. So perhaps in this TB-CRE initiative, we can make the first step in designing a protocol. We will lock ourselves in a room together for a weekend and come up with an amazing protocol. So with that, I would like to thank you for your attention.
Thank you very much, Jan Willem. Questions? Could I ask the obvious one? I guess for those of us who can't afford to maybe give up one hair from our head, do you see accumulation in any hair on the body, or is obviously the length of the hair on the head is?
That's a good question. I've seen how they work with the hairs and how they look at a single hair. I think the nature of the hair being stretched or, let's say, more curly could pose a little bit of a challenge for how they analyze the current single hair. Because what they do is they cut the hair through the middle, and I've not seen that done for other hairs than straight hairs that they did in their current project. But it is a good question.
That's exciting, thanks. So I guess it adds a lot of complexity, doesn't it, then, to TB programs if you have to personalise dosing. And so do you think we would need sort of software to help guide prescribers and dose adjustment? Because if you get an abnormal level, a low level, how high do you increase or decrease a dose? And what sort of other tools would we need to develop to support prescribers in the field?
Yeah, that's a very good question, because we can make it very complex, but you can also try to make it simple. For example, if we're talking about a drug as a fluoroquinolone, these drugs are well tolerated. So if we're talking about a dose increase from standard to a high dose, you could simply make decisions, we double the dose. And for most patients, that will be the best choice, because you're not going to give 600 or 700, or it's not transplant medicine with immunosuppressive drugs. So I think that we can do a lot of simulations and see which is the best practical choice for our patients.
Thank you very much. I like your call for clinical trials. I think we should do it. I think it needs to be done in multiple settings, though, because obviously there's implementation questions. I guess just this is a question about what types of clinical trials we might do. So, there's been a lot of work done recently, say through studies like Study 31 or the REMOX study and others, to try and shorten treatment duration. And they've been doing those trials with sort of a fixed regimen which they give to everybody. And I wonder what your views are on the potential of the next generation of treatment shortening trials to necessarily require a sort of a dose adjustment component, because if we're going to get from 4 months standard therapy down to 2 months or 3 months, whether the way to achieve that is by making sure we individualise dosing, and whether to sort of combine your idea of a trial in general with treatment shortening as being one of the objectives of the trial, because in Australia we have very, very high treatment completion without TDM. So I wonder whether that is the particular population and the type of question we should be looking at.
Yeah, that's a good question. What we could start to do is actually measure drug exposures in phase 3 studies, because that will already provide us with some ideas whether the patients with low exposure do poorer than the ones with higher exposure. We recently published an overview of those studies, and really none of them used that in their analysis. Some of them included it, but they just stored the data and waited till today to publish new papers from that data. So I think that we can do that better. Whether we should do TDM in those multi-stage trials for single drug exposure and then adjust for the 4 drugs that we have in that trial, I think it will make it too complex. We should try to think of a different design to study therapeutic drug monitoring, because we don't want to make it too complex. It should be simple. So ideally we would like to do start patient on treatment based on the characteristics. We can decide on a starting dose and then screen whether they hit their target and then bump the dose if not. Ideally that should be it. Perhaps in some patients you should do follow-up if it's, for example, renally clear drug and that function is lower or higher or whatever happens to it. But you don't want to do the weekly TDM as we do in our patients with a lung transplant or kidney transplant.
Yeah, just one more question.
Catherine Berry, MSF. Thank you so much for a really interesting presentation. I haven't looked at that data for a while, so it was great to hear some updates. In particular, I just was interested to understand about any cultural barriers you found with recruitment to hair studies. I think it's useful that, the hair sparing scenarios, but in areas where shaving is the main way of having head hair and also hair pieces. Certainly my own experience has been that recruitment's challenging, and then I guess the generalised acceptability for hair sampling is difficult. So I was just wondering if you'd comment and see if that was anything you'd encountered.
Yeah, so we have not started our trial yet, but we know that with the whole lock of hair collection there is resistance to that. So that's why I was really happy when I was approached by this company who could do it in a single hair, because nobody has an issue with a single hair, because likely if you just go through your hair, you already have your single hair. So that will not be a big issue, I guess. With the blood sampling, that is an issue, because in some cultures collecting blood is taking life from a sick patient. So we especially experience it also in China. And dry blood spots partly solves that problem, but not completely. So I think in those settings, saliva monitoring may be the way to go.
Okay, great. Thank you very much. We'll